Welcome in, ladies and gentlemen. Good afternoon. Glad to have you in. This is the Uncensored Pharmacist. I'm Will, your Uncensored Pharmacist, your host for this show. Glad to have you in. Yes, I got the hint doing the intro 3 different times. The countdown was confusing. I need to make an intro for this count. But until then, we're just gonna go to the generic 30-second countdown. All right. That's what you get here. All right. That's what you get. You should be surprised that we're even doing a show today. All right. They're sporadic. I don't know when they're going to be, but I had a lot of fun the other night with the show, and it seemed like some people liked it. We got like 100 and something new followers over on Rumble, so that was exciting. Shout out to Rumble. Thanks for putting us up top and giving us some exposure. Really appreciate that. Shout out to Mastering the Rumble, sharing out the link and pinning it to the Rumble chat and all that good stuff over there. And welcome in. I am Will, your Uncensored Pharmacist, coming to you live from the great state of Idaho. And I am your Uncensored Pharmacist, the best pharmacist on the planet. Best retail pharmacist, I should say. I don't like that hospital stuff. Anyways, here's what we got planned today. We're going to talk about opioids. Since, that's a big topic in this country, has been for a couple decades now. Actually, what brought this up was I have several topics that I want to talk about. Actually came across one yesterday about cholesterol and statins, and we're talking about medications that are pointless. So there's been like these things. What was it? So like phenylephrine it's common in a lot of over-the-counter cough and cold medications. It's supposed to help decrease pressure and sinus pressure and whatnot. And dry some things up there when you're sick and whatnot. Well, it comes to find out that, that most popular, that very popular over-the-counter drug for cough and cold season, it actually doesn't really help at all. And they've known about it for the last 20 years. And it was recent, like the last 6 months or something, like the FDA, some organization, I can't remember what it was. I'll have to pull up that article too. Came out and was like, actually, this is not beneficial. This is not helpful at all. So, that's great. After, I think it was like, I don't know how many billions of dollars they made off of, selling it. I think it was like $20 billion in revenue or something like that over the decades. They just said, oh, by the way, it actually is kind of pointless for you to take that. Oh, cool. There's a lot of things like that. And the statins are one of the ones I want to get into because there's a lot more evidence coming out now that it was all BS. It was all BS. What I mean by that, like I said this in the last show, and I'll keep saying this going forward, is when you look at drug studies, you can't just read the headline. We can't just, even if the FDA approves it for a certain thing, because that's what the headlines say, there's so much more into it. And one of my professors used to say, when we're talking about drug studies, this is for meta-analysis, where you take a bunch of different studies and you kind of group them all together to help create a meta-analysis, what it's called. So you have one big study of all these different studies, and you kind of take all the data from all those studies and put it into one and see if you can find something. What he would say was garbage in, garbage out. If you put a bunch of garbage studies in there, well, the results you're going to get is a bunch of garbage, even if it's what you're looking for. That's the same thing with just a normal study. A normal study, it's like, I like to tell people, it's like accounting, right? You can put up a bunch of numbers and you can choose to make the numbers say whatever you want to say. Doesn't mean that's actually what's happening, right? You can get very creative. You can only, telescope, zoom in on one thing, right? And not look at all this other stuff. So in this case, it's like with stat medications, and I got to do a little bit more research on this and kind of, I want to actually map it out before we talk about it. But this is one of the topics I want to talk about going forward in another episode. It's like, okay, yes, you have these statins, your Tor, so your Lipitor, for those people that don't know the generic names, your Lipitor is the most common one that people know. And like, yeah, okay, cool. You take it, yeah, clearly it does what you're looking for it to do. You want it to decrease your LDL, which is your bad cholesterol, and you want it to increase your HDL, which is your good cholesterol. Or so that's what we think. And yeah, if you just look at the study, that's what it does, right? That's what it does. So you're lowering bad cholesterol, you're raising good cholesterol. That means, that should be beneficial to your heart and whatnot, right? I mean, it should be overall general health should be great, should be good. You should be fine, right? But you're not looking at, okay, but does actually lowering your LDL or even raising your HDL, does that actually help prevent you from having heart attacks and strokes and all those other nasty things? Does that actually Is that actually what we're looking at? Well, if you look at a certain set of studies, it says yes. If you look at another set of studies, it says no. And there's more and more evidence that's coming out and said, yeah, okay, it does that, but just because you do that, that doesn't mean you actually are decreasing any risk of you having a major, cardiac event. So you're kind of taking these drugs for no reason. And what was it? I think I was looking at, it was like 4 point, maybe it was 3.5. Let's just say three. It was like the drug companies do $3.5 billion. So it's one of the most statins are, even though they're generic, they're one of the most prescribed and dispensed medications out there. So they might be all for naught, and they got nasty side effects. Some are rare, but they're still nasty, and there's a good percentage of the population that it affects. So that's just one thing that I want to get into and talk about. We've got a whole bunch of other topics. Today, we're going to be talking about opioids because someone in the comments got a lot of comments and stuff yesterday, and I try to read through those and respond to them. So if you have questions, wherever you're watching this, whether it's YouTube, X, Rumble, of course, we love Rumble, wherever you're at over there, comment and I'll try to respond to it. But someone was talking about, hey, let's talk about the opioid settlement and stuff that was happening. And there's a lot of other things that's going on with opioids and how the government tries to play doctor. And I have firsthand experience of seeing this from the pharmacy side of things. So we're going to get into that. We're going to get into that, how they try to regulate doctors. It's bad enough when insurance companies try to play doctor and tell you, yeah, oh yeah, doc wrote the script, but it's not on formulary. So we're not going to approve it. You don't really need that. You need to try these other things. It's real frustrating when insurances do that. It's even more frustrating when the government tries to step in and play doctor because the government doesn't do anything right. So we're going to talk about that, and then we'll lead into one of the other stories. I have a bunch of other stories lined up too that I was talking about. Maybe since we're talking about the government interfering with docs, maybe we'll talk about also one of the articles I wanted to bring up was doctors getting burnout and what's up with the doctor crisis in our country. Why is it impossible to get an appointment right away in this country? So we'll go ahead and we'll talk about that a little bit more, and some other stories that we'll talk about down the road. We've got fasting. Is fasting actually beneficial? Is what are the the health benefits from fasting, or are there any, or is this just another diet fad? So we're going to talk about a little bit about fasting, talk about there's some synthetic, fake sugars out there, the synthetic sugars that are causing blood clots and whatnot. So we're going to dive into that a little bit. There was one other one. What was the other one that I had pulled up? Man, I have so many of them. So many different things that I want to talk about. There's another fun one though. Forgot it. Doesn't matter. I'll go look at my email because I got a list of things. But today it's opioids, and then we'll hop into one of these other topics and have a good time. Speaking of having a good time, let's see who's here. I know Mastering was here earlier. Good morning. I'm so used to saying good morning because I'm so used to doing this show so early in the morning. It's nice. I think I'm gonna start calling these. I need to create a show and just call it nap time show for all the parents out there. You know who you are. Nap time show, when you get a chance, when all the kids are asleep, you get a chance to actually do something. That's why I do this at this time, because around noon 30ish, noon 30, 1 o'clock, I get to do this. But shout out to Mastering. Glad you're here. Millie Ghost is in house. They do not reduce the risk of heart attack, according to the data. That's right. That's right. Cholesterol is needed all throughout the body. Every nerve in the body is insulated by fatty tissue, every vital organ, etc. Exactly. That's the one thing from that study that it's famous from. I think it was back from the 70s or 80s. We'll get into that when we talk about that another day. But it was like, well, there's one guy theorized that it was cholesterol that was bad. One guy theorized that no, it's actually these processed food and sugar that's bad. And you can guess that they went the other route. The people funding the study went the other route and went with the guy that said it was cholesterol and trans fat and all that stuff, because big sugar can't be having you saying sugar is bad. No, that costs them too much money. I mean, if you just think about it, I mean, do we really see? I could pull up the data and this and the statistics on it, even though you can't trust any of these statistics that the government puts out. You really can't. It's the only thing that we can go off, but you can't. I mean, look at, they can't even get the job numbers right. I mean, they revise everything down the next month, right? They can't get anything accurate. They can't put out an accurate number on there on anything. So, but I would be curious to see, hey, are we actually seeing a reduction in heart attacks or strokes and all that? Because you would think with as much as these statins are prescribed, that we should be seeing a decreased risk. Or if you want to make the argument, well, a lot of people don't get put on them in time, so then they have the event and then they get put on 'em afterwards. Okay, then let's see how many people are having repeat offenders, having a second cardiac event afterwards, and see if that's gone up or not. Don't even get me started on physician shortage and how the government has made the healthcare professional how the government has made healthcare professionals the enemy. Exactly. Exactly. It's a combination of big business and the government. Um, that's something we'll get into later in the show, because there's a lot going on there. A lot going on there, but I'm glad to have you guys here. Glad you're hanging out with me this afternoon. Let me just make sure I got everything set up. I do have look at I pulled this in from work. So when we need to actually look up drugs and stuff like that, I got access to Micromedics, so we can pull up some things in there. That'll be fun. This is a nice little drug database that, for those that don't know, drug database that healthcare professionals use. Like I can type in, like we're speaking of statins, right? So let's go Lipitor. Is it Lipitor? I always forget. No, Lipitor. See, I can't even spell those names right. Atorvastatin. See, pulls up all this great little information that you need to know. FDA uses, different dosages, stuff like that. We can pull up they got black box warning on there, which I would say that I don't think that one has one, and it doesn't. You can look up, I mean, if you get real, we won't get this technical, but you can look up like mechanism of actions, and right, and you can go, that's the basic one. You get into in-depth answers and stuff like that. So it kind of has a little bit of everything. Good little tool for us to use when we need to pull up some stuff, maybe even pull up some stuff for these opioids. So patients need more extensive testing on what kind of cholesterol they need to target. Ask your doctor to do a more specific panel. That's a great point. I forgot to start the show off with this. Thank you for reminding me, AK. I am not your pharmacist. All right. I am not your doctor. I am just a guy on the internet here talking. I am a pharmacist, but I'm not your pharmacist. Don't trust me when I tell you I'm a pharmacist, because you should never just trust some random person on the internet that says they're a pharmacist or a doctor or whatever. So I'm not your pharmacist. This is not medical advice. Go speak to your own doctor or your own pharmacist and consult with them. There we go. Got that out of the way. But also it's the other thing too, Millie Goods, is what we're saying, but need more extensive testing. Yeah, the other thing is, the problem with this is we like to cookie cutter everything. We like to put put it all under one umbrella and say this is a one size fits all for everyone, and it's not. It's not, but that's how our healthcare has become. It's like we got these guidelines. Yeah, it deviates a little bit. We know some things, like this population, for example, like when high blood pressure meds, like the African American population, typically doesn't do well with the ACEs and ARBs. They do better with the calcium channel blockers and the hydrochlorothiazide, the mild diuretics and stuff like that. So they typically respond better there, because there's just some genetic things that differ us. But for the most part, we really just assume one size fits all, and it's a little trial and error of things. Especially when you get into the antidepressants. Jeez, that's a whole other story. That's like so much trial and error there is some genetic testing that's pretty interesting. I did get certified to do that, which was fun to learn about, and then the pandemic hit and I never even got to start doing the project I wanted to do. But you basically can with some saliva sent into the lab, you can get the it's kind of like the 23andMe type of stuff, but you get someone's genetic data, and you can go through and see, oh, actually, if we're going to start them on, for example, on an antidepressant, they're more likely, with this data, they're more likely to respond to this drug than that drug. Even though I think a lot of that stuff is a scam as well. It is really cool to see some things. You get a little bit, you can customize someone's medication when they actually do need certain classes of medication that you're not doing the whole trial and error, and you can avoid some potentially bad side effects that you didn't know about, that you wouldn't know about unless you had the genetic data. So that's fun. AK says, exactly. How can we mass produce to predict what the budget will be? Yeah, exactly. All right, let's get into this. So this is one of the comments, and like I said, I appreciate you guys commenting on here. So Irish Lass 43, shout out. I pinned it so I'd remember to talk about it. Says, can you talk about all the shortages caused largely by the opioid settlement injunction? People with serious illness are being denied pain relief. and pain that cannot be controlled by OTC or supplements, other modalities, etc. They're telling providers that opioids don't work, and if you don't taper their patients, they risk a raid and license revocation. And then she says, check that stuff out. So here's the deal. When we start with opioids, we're gonna have to like rewind and start at the beginning. Obviously, we know that it made the drug companies a ton of money. Um, but there was a need for it, or at least the government thought there was a need for it. So they came out with these drugs, and they were obviously a big hit. Pain relievers, right? Big hit. Synthetics. You might hear it called synthetic heroin, and that's what it is. Opioids, like oxycodone, is like synthetic heroin, right? So there was a need for it, and the government like realized that this was now a going to be a prescribed medication. So they come out and say, "Well, these drugs are pretty powerful. We need specialists. We need doctors to specialize in this field." And so they encourage people, doctors, to get your doctor and then go specialize in chronic pain. So we need chronic pain specialists. So a bunch of people did, right? A bunch of good doctors, and people do have chronic pain. Obviously, one thing led to another, and we're at where we're at now because um, bad actors all around. There's bad actors, and there's patients, drug seekers that went and seeked it and abused it. There's prescribers that would prescribe it and would just give it to everyone, give it out like it's candy, like it's Skittles. You saw all those operations. They didn't care because there was so much money to be made that, like, all those clinics that went down to like Florida and opened up clinics down there, and like just you walk in, you get painkillers, and then not knowing how damaging these drugs are and how addictive they are so fast. Um, so you had that happen, and I'm being real vague in general here because we could spend hours talking about this. So, and then so now all of a sudden there's an opioid crisis, and it's being recognized by the government. So the government obviously has to react to it because it's a political issue now. And so the government comes out and says, "Hey, we want chronic pain specialists," and now it says, "Actually, we want to regulate you guys now. We want to rein you guys in." And it's like, wait a minute, what are we doing? You're the one who caused this problem. You're the one who told us you needed us as specialists, and now you want us to, stop doing. Now, don't get me wrong. I've seen. God, it is sad. It's sad. And one of the problems too is it takes so long for like the government agencies to build a case against a provider because, I mean, let's be honest. I agree with this. Like, the government shouldn't be telling a doctor what to do. Shouldn't be telling the pharmacist what to do. I mean, there's general, obviously, rules and laws that we need to follow, but like when it comes to prescribing for a doctor, you have the degree. The government doesn't have the degree. That's why we don't just go along the government guidelines and just say, well, this is what the guidelines say here, so this is how I have to treat this situation. No, you have full reign as a provider to prescribe what you want, treat your patients how you want. Nowadays, that's not the case. I mean, it is the case, but people are getting so brainwashed in school and schooling. I went through it in pharmacy school. I graduated in 2017, so I'm fairly recent of the new prescribing habits, and I saw, or the teaching habits, and I saw firsthand that they want to brainwash you and teach you need to follow these guidelines. These guidelines are gospel, not knowing that guidelines are just that, guidelines. Okay, they're a good starting point. They're a good. Hey, I need a refresher. I got something here. Let me go see what they say, what the guidelines say and recommend. And then you build upon that. You don't just strictly rely on the guidelines. If not, then a freaking robot can do your job for you, right? A monkey could come in there and follow along like, okay, you've got this. That means we got to treat this with this at this and this dose and that. Okay, here you go. Here's your prescription. It's like, it's not that simple. Sometimes it is, but it shouldn't be that way for everything. That's why those older doctors are so valuable because they've seen so much stuff. They've got real life experience. It's amazing. So you want to get you a doc that can think outside the box, or think for themselves, I should say, not even outside the box, think for themselves. So you've got a problem, people abuse it. So now it's the government saying, hey, we need to regulate this. We need to crack down on this. And so they want to go in and start, telling these doctors, hey, you can't do that. And they're going to start investigating doctors. And they do investigate. And listen, a lot of them, I was there with this one doc. She was abusing it from where I first worked. She was, and it took them 2 years to build a case against her. and bring charges and whatnot and revoke her license. And in that case, it was I believe it was deserved, um, because of what she was doing. She was clearly doing illegal stuff, and her prescribing habits were terrible. I watched so many kids get their, like a course of over 4 to 6 months. This one patient of mine, just you could just tell it was going downhill, downhill, down. It kept getting more and more stronger and stronger painkillers from the same doc at ridiculous quantities, and it clearly was a problem. And what I say about this doc is it's not me to judge how they want to treat chronic pain. I don't even think this kid had chronic pain. Originally went in there. You hear this with athletes a lot. AK will know this. You hear this with athletes a lot that roll their ankle or something like that, or you had to have to get some surgery on a body part, right? Let's say an ankle. You had to get some surgery, so you get some you get a little prescription of some oxycodones or something like that, just a short term acute therapy. Then they get hooked. They get hooked real fast, and the docs feed them some more, feed them some more. The next thing you know, I mean, I had one gal that stole a prescription pad out of the doctor's office and was writing her own scripts, and I could tell the script was fake because it it didn't have medical terminology on it. Not that all scripts do, but you could just tell. And then obviously the signature was off. But the way the prescription was written was not how anyone in the medical field would write a prescription. So that was a red flag. But it's just sad. Like you just start ruining lives with these with doctors getting, you know, I don't think prescribing someone with like pain medications for surgery and they end up getting hooked on it. If it was a reasonable amount, like a 5-day, like you give them 20 oxy fives to last them 5 to 7 days. Okay, that makes sense. If something happens, they end up getting addicted to it because I don't see how the doc could have known that was going to happen. Now, if you keep prescribing it to them, knowing that they have a problem, then yeah, that's a problem. But the other thing is well, I'm getting ahead of myself. So let me continue with this. So the doctors come in, this lady that was prescribing it, she was also doing some shady stuff in the back. So like she would prescribe it to these guys, her patients, and then her patients, she would prescribe high quantities. Then they'd have to come back and give her like I will just say half. This is what was alleged. I'm saying this is alleged. They would give her like half the script of oxys and she would go sell them or do whatever she wanted with them. Obviously, bad actor there. That's not okay. By any means. Abusing your power and doing illegal stuff that you're not supposed to be doing. We had that happen. So then the government comes in and says, hey, yeah, we're going to regulate this. But then so they come up to you if you actually do have a bunch of chronic pain, you're a chronic pain specialist and you do have patients that are, you know, who have chronic pain that actually need some of these medications. And they're trying to tell you, no, listen, you need to be at this dose. You can't prescribe more than the standard now is 90 morphine milliequivalents. You can't per day. You can't prescribe more than that. And it's like, well, a lot of my guys, a lot of my current patients are on more than that, and it seems to be working for them. Now you want me to decrease down, and you want me to do it like they give you a month, right? They're like, yeah, we need to see this change in a month. It's like you can't just wean someone off of that, right? Another problem with this is you have opioids and benzos. So like your Xanax, your so alprazolam, lorazepam, diazepam, Valium, Xanax and Valium. For those of you out there, they get prescribed with opioids, and that's a terrible combo. We found out, but it was real common to prescribe both of them, and you get people hooked on some high doses of benzos, and that is really hard to come off of, right? You can't just someone who's on high doses of benzos, you can't just say, okay, we're going to need to decrease you down by half, right? Or we're going to listen, because a lot of what they're saying was like, you can't prescribe, where we've got you now is like, you can't fill a prescription of a benzo if they're on an opioid. It's like, well, they've been on both of these for a long time. I can't just have them go cold turkey. They stop their benzo. They're at a very high risk of having a seizure and dying. You got to wean and to come off these drugs is nasty. You got to wean off for a long time, but they'd come in and be like, you got a month. It's like, oh, that's cool. So they'd come in and they try to tell doctors, hey, we're going to investigate you. We're going to look into all this if you don't change your prescribing habits. I have a problem with that. It's one thing if it's like the doc that's like selling, has a side business and has her patients come in and give her some of the opioids and goes out and sells it on her own or takes it on her own or whatever's doing with it. That's yeah, that should be investigated. But to be like, Listen, you're not following what we want as a government. We want you to be only to be able to prescribe this at this amount. So if you don't change, we're going to investigate you, threaten to take your license and whatnot. But really, they have no power over a doctor because a doctor just falls back on, I'm the one with the medical license, right? Maybe the state wants to come in and pull my medical license. You're going to have to have a reason for that. But like the DEA and stuff can't just come in and say, hey, you need to follow these rules because it comes down. That's the doctor. He's the expert. He or she's the expert, the specialist, right? And so how does the government get around that? It's like, man, we can't really go at them directly because yeah, I mean they technically, as long as it's within their scope, right? Would a reasonable provider be doing this if it's within their scope? Sure. Yeah, okay. So how do we get around that? Well, we go regulate the pharmacies because they've got to go fill these scripts somewhere. So what would happen is you'd have these like opioid mill towns. I came from one that doctors would prescribe a bunch, but they would come crack down on the pharmacies. So you come into a pharmacy and be like, you're dispensing way too many opioids in a month, like way too high. You're way too many pieces. They could count it by pieces of of oxycodone or hydrocodone or whatever. How many pieces are you? Yeah, it's way too much. And they come in, they raid you, they look at everything. It's very scary as a business, but like this is happening to chain pharmacies in the area, right? And of course, corporations are freaking out, so they're going to just bend the knee and do whatever the government recommends. So then it's like, if you don't stop doing this, then you are going to get your DEA license pulled. And if you're anyone, for anyone out there that don't understand how big of a deal that is, a pharmacy can't operate without a DEA license. It's damn near impossible to be a pharmacy that doesn't have a DEA license. Like you're not going to be profitable. That means you can't do any controls, not just opioids. You can't do any controlled medications, and there's a lot of controlled medications that people are on. So you can't do any of them because you can't order them and you can't dispense them because you don't have a DEA license. So they go and threaten the pharmacy. So now the pharmacies are putting all these pressure on their pharmacists, saying you've got to follow these guidelines that the government wants us to follow, which means the pharmacist now has to deal with the patient and tell the patient, hey, I know you've been on this for a long time, but now we can't fill that for you unless you follow these rules that they want us to follow, which are crazy. It's just crazy that they expect you to drop down your to just get rid of your benzo. You've been on Xanax 2 milligrams 3 times a day for 5 years, and all of a sudden they want you to go cold turkey. That's not right. That's not ethical. That's you're going to put that patient in the hospital doing that, right? But that's what they want because they're going to threaten to pull your license. So what do you do as a pharmacist at that point? You're stuck. Then they also want you to call the doctor's office and get all this information. What's your diagnosis code? What are you treating? What's your therapy? What's your plan? When's the last time you had a visit? It's like, I'm a pharmacist. I don't need all this information from the doctor on this. Like I feel like I'm overstepping my bounds, but I got to fill this stuff out because corporate's telling me I got to fill this stuff out because the DA's telling me I got to fill this stuff out. So now I'm being a pest to the doctor, and the doctor could just turn around, piss off, and say, "Shut up! I'm the provider. That's what I want them to have." And they do say that too. They do say that. That's like at a point I get it. At a point I get it. But yeah, so that's kind of where we're at with the opioid stuff, like how government steps in and wants to it's just dirty. It's a dirty business. So the title is DA plays doctor. That's what they do. They're trying to play doctor, and if they can't, you know, put pressure on the doctors directly, they do it indirectly by putting pressure on the pharmacies. And that creates its own craziness and whatnot of like I was just saying, it's like now the pharmacist is the bad guy, right? Um, I don't want to see anyone go down that path of opioids and be addicted to those things and have to take them the rest of their life. But there's some people that, I mean, I don't think as many people that are on them need them, but there are people out there that need them that have real chronic pain. That some of these things work for them and they're okay with it. And I'm all about, that's their choice. As long as they have informed consent, they understand the risk, and there's an outlet if they ever want to seek help and come off it, which there's a ton of outlets to start working off of these things. But yeah, having the government come in and say stuff about it is no bueno. Let me catch up on the chat real quick, and then we'll continue down that. I always say it's called pain management and pain solutions for a reason. Yes, athletes and military personnel. Yes, too many military personnel. Yeah, I could see that. I haven't had any experience with the military personnel myself, but I definitely could see it. And then yeah, athletes. I've had a lot of experience with athletes and whatnot. But yeah, that's kind of the opioid deal. going on there. Like I said, we can get into like super detailed stuff about all of that, and maybe we will in further shows. I just wanted to right now kind of just give a little brief overview of like, hey, that's what's going on. It's like this is a constant battle, and the current recommendation is 90 morphine milliequivalents. So now that the government states that, guess who steps in line with that? All the chain pharmacies have to step in line with it. That's why it's impossible for you if you get like a, let's say you're having intense surgery and you are going to need some heavy painkillers. Um, it's impossible for you to, like, get that filled at most places because 'cause they'll tell you, now you're over the limit on some things," and it's not hard to go over the 90 morphine milliequivalents. I mean, it's a good amount, but it's still not hard to, and so you have a lot of pharmacists turn people away, pharmacies turn people away because that's just how big corporation has been. The corporates, they just follow the rules, and you have to do what corporate says. It sucks. You can't just be your s I mean, you can't make your own clinical judgment as a pharmacist. You can't just sit there and say, "Hey, this is a lot. Let's take a look." And then you dig in, you get some more information, talk to the patient, maybe even talk to the provider and just get confirmation. Hey, this is not pain solution. Oh, not pain solutions. Yeah, it's pain management and not pain solutions. That's right. Um, because they're still in pain. You're just managing the pain. A lot of people that are on those chronic opioids, they still have some pain, but they're not hindered, right? They can live their everyday life. They'll have a little bit of nagging pain, but um it's not like it makes the pain go away. It's literally just like a blanket that covers it up. It's like, it's crazy, but, it just dulls it and numbs it. But yeah, so, where was I going with that? We were going, lost my train of thought there. Anyways, you can't get anything filled sometimes, and it sucks as a patient. It sucks when, as a provider, I can't make a clinical judgment, right? I can't, like, say, "Oh, yeah, you are having this surgery. That's cool." Um, I forgot because I work in independent pharmacy, so I get to actually be a provider and make my own judgments and stuff like that. My wife, when she had her C-section with our twins, I went to go fill. So my pharmacy is about an hour away from where I'm at, so I went and filled her. She got some opioids, and I went to go fill them, and she ended up not even taking them. She just wanted them just in case. But I went to fill it out at Walmart. And the pharmacist, she's like, "Oh, hold on, we have to have the pharmacist come talk to you." And it's like, "Oh, okay." She starts grilling me, asking me these questions and stuff like that, and I was like, "Oh, yeah, I forget," because it wasn't like it was just a couple of them. I'm like, "Man, this seems pretty intense for just a couple." I forget. This is corporate, right? This is corporate. And then I just told her, "Oh, yeah, my wife, it's for my wife. She just had a C-section." She goes, "Oh, cool." She wrote down the right thing. She's like, "Okay, yeah, yeah." And I let her know I was a pharmacist too, so if she had any questions and whatnot, I mean, I can get the information that she needs. And she said, "No, it's good. We're good. I'm just gonna write the diagnosis code on here, and we'll be able to fill this." And it was great. But I was just like, "Oh yeah, I forget that it's so regulated. It's not regulated by healthcare professionals, regulated by the government, which in turn also insurance regulates things. Insurance won't cover opioids. They won't cover certain things. It's real tough when you have to sit there and tell them, yeah, your insurance won't cover this because of you can only get this amount according to them, or you can only have this many a day according to them. Which a lot of people are like, okay, cool, then I'll be a cash pay customer. I'll just pay cash for it. That's fine. Which then also it sucks because it's a red flag. You got to really trust your patient because they could, you know, cash paying with opioids is just a red flag in general. If you see anyone come in and pay cash for it, you got to, if you don't know them, you got to look it up and see if they filled them elsewhere. So that way, they're not just pharmacy shopping. But then, you build a relationship with certain customers, you'll know which ones aren't pharmacy shopping and whatnot. And it's not hard to look them up with the databases that they have now. But it is a red flag though if you have like a bunch of people on a cash paying for opioids. The government sees that, the DEA can see that, and they'd be like, "Well, what's going on here?" And then it just opens you up to being investigated and raided, and not fun at all. Not fun at all. Not good times. But we'll get into some more stories about that. I wanted to give a general overview. Thank you to Irish Lass 43 over there talking about. I don't know about them telling that opioids don't work because they do work. And that's not the issue with the DEA or with governments or whatnot or stuff. It's we've had bad apples that's kind of ruined everything for everyone. Oh, that's what I was gonna say too. It sucks when there are like a Medicaid patient, because Medicaid is like, oh, we're only gonna pay for this much, and like you can only give them a certain amount. And then you have to deal with that patient and explain to them, no, you can't pay cash for it because you're on Medicaid. We'll both lose our Medicaid license if I let you pay cash for these. And so they make you, the pharmacist, seem like the bad guy. Um, but it's the insurance. And that's one thing as a pharmacist, how tough it is to like learn how to deal with patients when it comes, not even with just opioids, but like in with prescriptions in general, of like, hey, your insurance isn't going to cover this, or if they do cover it, you have a huge copay. Well, why does it cost that much? I'm like, listen, that's between you and your insurance and the insurance plan you signed up with. I can only tell you, I don't know if I can look and see if it's going to a deductible or what, but like I'm not the bad guy here. I want you to have your meds. All right. I want you to have all the meds that you think you and your doctor think you need. And I'm here to help you. And if you got any questions about it or concerns, I'll answer all your questions. When I want you to have it. Your insurance is the one that telling me no, or you can't get it till this day. Okay. So I'm sorry. And you have to learn how to I don't want to say spin it, but just be like, hey, I'm not the bad guy here. It's your insurance. Go fight with them. I'm just trying to do my job and help you make sure you're educated on what you're taking and make sure that you get the therapy that you need. But here's what it is there. Here's what it is. You want to get into, let me pull up this other story that I got going for us here. I gotta pull up my email real quick. But we will talk more about opioids down the line. Okay, that's not what I wanted. That's not what I wanted. Go there. There we go. Let's go here. Let's switch over and talk a little bit about. Let's talk a little bit about. Where's this article? Sorry, I'm looking for this article. Are do I not? Hmm. There we go. There we go. I think it's this one. Our doctor crisis. Okay, sorry about that. I should have had this pulled up beforehand. My bad. Get rid of these ads. Okay. So what's behind America's doctor crisis? Came across this article, thought it was pretty interesting. Figured we talk about it. Why is it so difficult to get an appointment? Like, we moved here last year. My wife was trying to get an appointment with a provider, right? Actually, it was actually pretty easy for her to get in with, oh, look at this dude, with her baby doc. But after that, like, you're getting a PCP. I mean, this was like March we were looking, and they're like, yeah, we don't have anything open till October. I was like, what? And then so it's like, okay, then you got to go to urgent care if you want something. But then in urgent care, there's certain things that they just won't prescribe you, just because it's an urgent care. Like, you need a primary care provider to do that. And it's like, well, I'm trying to get a new primary care doc because I just moved to this area, but no one's taking on new patients. Why is that? Let's go through this article a little bit. Why is that? My general overview of this is, you've got, why is it so hard to get into the docs? It's not because we don't have more doctors or more pharmacists, right? They're pumping out those things left and right out of these schools. So it's like, what's going on? Well, the problem is you've got so many people that need to be seen for things, and doctors are now not allowed to be doctors. They're basically, you go into a job, and you've got 15 minutes with a patient, if that. You've got to diagnose, assess, run through everything. You don't even get a chance to really build up a relationship with the doc or with your patients, because you're just a factory. It's like a factory, in and out, in and out, in and out. Because you got to boom, 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 boom. Get all those patients seen, get them taken care of, get them sent out the door, and then by the way, you got to write up your whole report, but you don't even have time to do that in between patients, so you got to do that afterwards, and then you end up taking work home with you. and then you get stressed out and burnt out because your whole life is trying to stay on top of your work and what you got to catch up on. So it's crazy because these clinics now they expect these doctors to see 4 or 5 patients an hour, if not more. You know what I mean? So a lot of burnout, a lot of burnout. Let's see. Securing an appointment to see a doctor in the United States is exacerbated by soaring healthcare demand and fewer doctors. Many specializations are increasingly. In fact, that's the other thing too. That's the other thing. A lot of these docs, because they don't have time to really be a doc, they're there for just primary care stuff. Anything where it starts even getting remotely complicated, they send you out the door and say, "You got. Let me refer you to this specialist. Let me refer you to that specialist." They don't get a chance to really, which I mean, not that that's a bad thing. Like if there is, there's certain things for specialists that you need to go see, and certain things that a more specialized doc needs to see. But it feels like more times than not, you're getting referred to this. Then you got to go do labs. You got to go somewhere else and get labs, and then once those labs get back, you hope you hear something from your doc in a portal, or hope you can come back and talk to your doc. By the way, it'll take you another 4 weeks to get back in with your doc to talk about your labs that you did 4 weeks ago. you know, it's crazy. Many specializations are increasingly affected by this trend, but primary care and emergency medicine are amongst the hardest hit. The average wait time to see a doc has increased since 2017 and continues to rise after the demand spike brought on by COVID-19. A survey conducted by AMN Healthcare in 2022 of 15 large metro markets revealed the average time to see a physician was 26 days, an 8% increase from 2017 and a 24% spike since 2004. That is crazy, especially the many docs as we have now, like people graduating and getting their degrees and stuff. The fact that we still can't get people seen, and that the demand to be seen is that much higher. We are just such an unhealthy country. It's insane. And they're saying this is, average is 26 days. I wonder if that also takes in if you already have a doc, like you already have an established primary care provider and you call in and you need to make an appointment. Maybe it's that. What if you need to find a new primary care provider? That's what I was saying with my wife. It took us months. I mean, we're still waiting. She still hasn't been seen. She's got an appointment next month, September. We did this back in March. And it took until September for her to get seen. She still hasn't been seen. And hopefully her doctor doesn't call out that day, because then that throws a wrench into everything too. You know what I mean? Staff constraints are also felt in hospital emergency departments. Nearly 140 million Americans visit a hospital emergency department in 2021. A lot of that too is because you can't get seen anywhere else. So where are you supposed to go? You go to the emergency department, right? Based on data from the Centers of Disease Control and Prevention, of those, 13% resulted in hospital admissions, while thousands waited hours to see a healthcare provider. Yeah. Don't try to go there unless you absolutely have to in the middle of winter, because you're going to be waiting a while and you're probably going to catch some bug from someone else. Let's see. One study analyzed more than 1,000 hospitals between 2017 and 2021 and found those with the worst performance had 4.4% of emergency room patients leave before a medical evaluation was conducted. That is true too. Part of that too is, though, we have a problem, and you won't hear many people talk about it. We have a problem with like Medicaid, and I got nothing against people on Medicaid. All right, a lot of people I went to school with were on Medicaid during pharmacy school because they were too old to be on their parents' insurance, and obviously they're not making any money because they're in school, so they need to be on it. Medicaid's there for a reason. Yes, but it's too many people are on it. Too many people abuse it. And the system is just made that way. It's not, I'm not saying it's anyone's fault. The system makes it that way to where, being on it's more beneficial and better for you to be on Medicaid than try to come off of it and get private insurance. Private insurance is stupid expensive. Anyways, that being said, so Medicaid, because they get to go to the emergency room and get seen if they have got the sniffles, where normally you go see your primary care doc, or you go to like an urgent care instead, right? You go to an urgent care, go get seen there for a cold. No, I want to go to the emergency room because I don't have any of those other places to go, and I can go there and I don't have to pay for the emergency bill. Whereas if you have private insurance and you go to emergency visit, you're going to have a fun little copay coming your way in the mail in a few weeks after. It sucks. But that's I mean, you have all those people that aren't Medicaid that come in and go to the emergency room because it doesn't cost them anything, and that just takes up, makes longer lines, takes up seats of where people who actually need to be in the emergency room can't get in there. It sucks. It sucks. Like you shouldn't go to the emergency room just because you don't feel good because you have the flu. You know what I mean? A lot of people do though. Worked at a community health clinic and we had an urgent care in our office, and a lot of people would come in and go to the urgent care, and literally the doctors would prescribe to us, and we're their pharmacy right next door, and we'd fill the scripts from Pedialyte, Mucinex, Tylenol, ibuprofen, like over the counter meds. I'm like, why are we prescribing this? Why don't you just go over there, get your over the counter? Why don't you just go? If you're not feeling good, drink some fluids. If you need some Tylenol or ibuprofen or whatever, take that and stay in bed, have some soup. Gonna be a few days, and you'll be just fine. Instead, you went to the doctor for the doctor to tell you that. It's crazy. Um, But yeah, that's crazy. So 4.44% of emergency room patients left before they got medical attention. And at the end of 2021, that number had risen to upwards of 10%. Damn, that's crazy. Compounding the issue is nearly half the doctor population will reach retirement age within the next 10 years. That also sucks because it's not like, geez, that is a high number. Half the doctor population will reach retirement age within the next 10 years. Doesn't mean they're all going to retire. A lot of docs keep working just because cost of everything's gone up and it's hard to walk away from that paycheck. But the other thing that sucks about this is not only that you're going to have way fewer docs. A lot of those older docs, like I said, they've seen a bunch of stuff. They've got real life experience. They're not following just basic guidelines. They're not just gonna go along with the guidelines and that be it. No, they can actually think outside the box, and they've seen so many different things that they know. Hey, no, this is actually the route we need to go. So that's scary too, that we're going to lose all those great minds. Almost 50% of doctors report they feel burnt out. Yep. Yep. Burnout it's the same thing with you see doctors, just think pharmacists as well. Pharmacists experience the same type of burnout in a different way. And we'll talk about that one day. Probably on one of these upcoming episodes. These are key factors driving America's growing secrecy of doctors. Physicians Thrives of 2023 study noted that the United States may have a shortage of 124,000 doctors by 2034. I feel like also they put this stuff out there because they want more and more people to go to medical school. And so they want these medical schools to, like when I was in pharmacy school, our graduating class was like 88. And the classes below me, like the first year or second year classes were like 160, like almost doubling. I think not freshman, but first year class was like 200 if you count both campuses, because they got a second campus, of course, why not? And yeah, so they're just trying to pump them out because all that is more money for the schools. So part of me, when I see things like this, I get skeptical and think, oh, they're just put signals out there to give the okay for these schools to admit more students. Which I don't even think you should have to go to school to do most of the stuff, but that's another topic for another day. Within that shortfall, up to 48,000 will likely be lost from primary care, while the industry is projected to lose another 58,000 specialists, surgeons, and nurse practitioners. That's not good, especially in your rural areas. It's not good at all. This is definitely coming down the pipeline. It's been coming for a long time, and we're seeing this all across healthcare. Emergency physician Dr. Jared Ross said. Dr. Ross is also president of Missouri-based Emergency Medical Services Education and Consulting. He watched Americans' healthcare workers crisis unfold on the front lines and says the shortage of physicians is an old problem that's reached a tipping point. This is also why I never worry about not finding a job. Because I know I'm really good at my job, and you're telling me that we're going to have a shortage of things too. So yeah, I'm never worried about. I've never not gotten a job that I've wanted. Let's just say that. Some of these provisional solutions include bringing in more practitioners from foreign countries, medical school loan forgiveness programs, expanding telehealth. Oh, more and more government spending to help solve this problem. That'll do it. We didn't get here because of government problems. No. Let's just ignore that. The government created this problem, but you know what? We'll throw more government at it, and that'll do it. That'll do it. Dr. Ross has seen Dr. Shortage impact emergency medicine, but maintains primary care has really struggled to retain physicians. This is critical for two reasons. One is because healthcare demands in the United States are rising. The average number of times Americans visit a doctor per year by age group is 4 times for adults, 9 for infants, and twice for children between the age of 5 and 15. That's a lot. That's a lot. Especially since there's a bunch of people that don't never go to the doctor. You know what I mean? Kids, I get it because kids get. I mean, if your kids only get sick twice a year, you're that was a good year, right? You know what I mean, they go to school, they get all this gunk, especially little kids, daycare and stuff. It just happens, and there's only one way to get. Well, unless you come to my pharmacy, I can prescribe you guys some basic general stuff of medicine. But most places you have to go see a doc to get your kid like an eye. If they've got like a pink eye thing or something like that, or if they got strep throat, or they've got a sinus infection or something, you have to go see doc. Earache is a big one. Problem is we have an insurance system that is a massive bureaucracy. There it is. The insurance companies. I knew they were going to work their way into here. So he says the other reason is due to it's called corporatization of medicine. Yes, that's not good. The problem is we have an insurance system that is a massive bureaucracy. That is true too. I hate insurance companies. During the recent conference with other medical leaders, Dr. Ross said it was discussed how America has really pushed away from the model of traditional healthcare. God, ain't that an understatement? That's an understatement. It's crazy. You got all these insurance companies and government agencies trying to play doctor instead of just letting the doctors play doctor. There's a general consensus within the group that insurance companies have become too powerful in medicine. Amen. The administration burden or hassle, as many doctors describe, is very disheartening. Dr. William Schaffner, infectious disease specialist at Vanderbilt University, had said. Having worked with medicine for more than 40 years, Dr. Schaffner has witnessed it evolved into something aggressively more complicated as insurance companies expand power over doctors. He says that this trend became more noticeable in the 1990s, and that is so true. Half the problem, docs get to a point where like, I'm not even though I think this is the best thing for you, I'm not even going to prescribe it because I know your insurance is going to say no, and I don't want to do the prior authorization because I know they're going to deny it anyway. So why waste my time? Why waste your time? And they give you a more inadequate therapy, I guess is one way to say it. They've not given you what the best thing you could possibly get because they know the insurance is going to pay. And then it's like, well, you could pay out of pocket for it. Not really. A lot of people can't. Either you can't afford it because it's stupid expensive, or you're on Medicaid, so you can't pay out of pocket. It sucks. Sucks all around. Doctors didn't go to school. Doctors didn't go to medical school in anticipation of arguing with insurance companies. It's depressing and discouraging. Yes. Now, also, when you see doctors, remember put pharmacists because we do the same thing. We deal with them every single day, just like the doctors do. We get on the phone lines with them and argue with them, and it's a big old pain in the ass. But we have to do it because we work for our patients. We're on the front line for our patients. We'll go advocate for them, and we'll do everything we possibly can. But at the end of the day, it's the insurance company saying yay or nay. In 2020, for the first time, fewer than 50% of U.S. physicians worked in private practice. That is crazy. According to the AMA, most have chosen to become employees of large medical groups, which has drastically changed the paradigm of health. The shift from the independent practice is emblematic of the fiscal uncertainty and economic stress many physicians face due to statutory payment cuts and Medicare, rising practice costs, and intrusive administration burdens. God, we'll talk about that. We'll talk about in pharmacy, that is all the same too. I mean, there's a lot of things that that's why you see all these independent pharmacies going away. It's so hard. It's so hard to be profitable as an independent pharmacy. It takes rare situations, kind of like one of the situations that I'm in. Very fortunate that we do really well. Part of it's too is because I'm pretty damn good at my job as well. The move from independent practice to medical group employees presents its own dilemma. Aside from increased patient loads, it has left doctors at the mercy of having to get prior approval from insurance companies. That's when you hear, oh, you need a PA or you need a prior authorization for this. That's what they're talking about. They need prior approval from insurance companies to carry out medical treatment or procedures, which is insane. Once again, they tell you, hey, I want to prescribe this for my patient. You're going to have to do the prior auth on that. And even if you do, which means they got to fill out a bunch of paperwork, diagnosis codes, and tell you exactly like what's going on here, why they need it. And then the insurance will be like, nah, it's not formulary. We're not going to cover it. Or, nah, how about they need to try this drug first? And if they try and fail this drug, and then they try and fail this other drug, then we can do this drug. And it's like, really? You're going to make the patient take unnecessary medications that might not even work when you have one that the doc is telling you is the exact one that they need, but you get to play doctor? It's crazy. Prior authorizations are an absolute headache, he said. Physicians are now stuck. Sorry, I missed it. So this forces a quantity over quality approach to treatment. Prior authorizations are an absolute headache. Physicians are now stuck battling with a third party who creates as many roadblocks as possible because they don't want to pay out. Yeah, they don't want to pay out, yet they're going to ask you every year to pay 20% more in your premiums for the same exact coverage because they're hurting so hard. Dr. Schaffner said it took numerous phone conversations with insurance providers so a family member could get a necessary medical procedure done. And that's not just medicine. That's right. It's not even medicine. It's for procedures, for them to cover certain procedures as well. It's insane. He said part of why it's challenging is because there needs to be a level of trust on the insurance companies end. It's not just a formal relationship that happens, but there also has to be trust that develops with the benefits manager. It can take time, said Dr. Schefter, and there's more about it. And maybe we'll cover this going forward. Maybe we'll check it out another time. But yeah, man, that's a little glimpse of why we have a doctor crisis, and I would argue also a pharmacist crisis in our country. The mental health of being a healthcare provider, being a pharmacist, doctor, or what have you, it's tough. It's not easy. Used to be like, when I was growing up and say, oh, you need to go be a doctor, be a pharmacist, do this. And, I went and did it. It was viewed as a good thing. And now I would never want any of my kids to go into healthcare. No, I don't want, I've gone through it. I'm in it. I don't want them to have that life. That's what they want to do. That's on them. But I do not wish that upon anyone. What's up, Iceman? He says, insurance companies, those bastards, that is not covered. Neither is this, and no coverage on that. And here's your premium. That's right. That's right. They go, hey, actually, you need to try this drug instead. Try and fail it. It's like, oh, so you want me to try this? It's probably going to fail because my doc, if he thought it would have worked, you probably would have prescribed that instead. So you're going to put me at risk for adverse side effects, or just not even just adverse side effects. Let's say you're lucky enough to not have any of those side effects, but you didn't get your problem treated, and you have to wait and wait and wait to finally get whatever medical problem you have treated with the right drug, all because the insurance companies don't want to pay it, and they force your doctor's hand. It sucks, man. But that's the game we play. And I want to talk about this more, and the reason why I started this channel and started doing this is because, one, I need to vent on some things, but two, I feel like things like this, it may seem very basic and very common sense like, but I feel like my generation, and definitely a generation younger than me, they don't understand our healthcare because they're not in it. They don't have to deal with it. Maybe here and there every once in a while, right? But they're not in it. They're not chronically in it. And you start getting into your 40s and 50s and 60s, 40, 50s and above, and then you start really getting into it and you see how screwed up everything is, but you need to be aware of it now so we can make changes now. The only way we make changes is if more people are aware of how screwed up things are. No guarantee that there's going to be a change, right? But the more we can educate people, the more, like, even if it's just a few people on here, more people I can help educate about this. I'm in it, so I see it every single day. I live it. This is my life. The more we can make people aware of it, and hopefully we can start, getting. Sadly, we have to get Congress involved. I would just love the government. Sadly, it's funny. We have to use the government to make change, even though the government's the problem in a lot of this stuff. The government's the problem. But and also just to avoid what not to do, right? Because you always hear these politicians are like, oh, we're going to go after big business. We're going to go after those big greedy insurance companies, and whatnot. Meanwhile, those drug companies, insurance companies are the ones that are lining their pockets from their lobbyist, so they're not going to do a damn thing about it. So we got to make sure that when government wants to regulate something and crack down on our healthcare, that we don't get tricked by a headline, by like a title of oh, we're gonna we're gonna put an end to the opioid problem. For example, we were talking about opioids. We're gonna make it to where these drug companies can't produce this much. They can only produce this much opioids a year, which they already do have, by the way. And that way these providers can't prescribe it, and pharmacies won't be able to dispense all these opioids, and that way we'll decrease the amount of opioids that are out there. And it's like, well, that's going to cause its own problem. You know what I mean? I mean, you're trying to solve one issue and you're creating a whole other wave of problems of why that's a terrible idea to do that. But they come up with crazy, stupid ideas all the time. And we need to be aware of when we are coming across one of those stupid ideas. And we need to push back. And the only way we can push back is try to educate the people that aren't aware that there's an issue. Because young people don't deal with this. They don't. Not until you start to, like, it starts affecting you. Like, you're sitting there and you're thinking, man, why am I paying this much in premiums? Why do my premiums keep going up? I never go to the doctor. Why do I need healthcare? It's like, oh, well, I have a family. So what if there's an emergency? I need this. What if something happens? Or what if you're starting a life, you get married. Of course you need health insurance. Why? Because good luck trying to pay those hospital bills for giving birth. Even with private insurance, I paid $17,000. I hit my out-of-pocket max, $17,000 for my wife to have our twins this year. That is insane. That is insane for anyone. I know that I'm a pharmacist. I have a nice salary. I also have, six-figure student loans and, well, I guess rent now, not a mortgage. I sold my house, but still, I got a whole bunch of things to pay for, right? It's not easy for anyone to pay $17,000 out of pocket just because my wife and I decide to expand our family. Yet, if you're on Medicaid, you don't have to worry about that. That'll be another topic another day. Iceman says healthcare and common sense. Oh, I don't think so. No discount for two for the price of one. I guess there was a little bit of discount, some things, but no, because each baby gets their own nurse. They get assigned everything, and it would have been more. It cost way more than $17,000, which is also stupid. I'm just saying that was my out of pocket max that I reached on my insurance plan. So all the other healthcare stuff that we've done this year, we don't have to pay near practically anything on because I've already hit my max. But it's just crazy that it's like costs $50,000 to have a baby or have twins between what myself and my insurance company paid. It's ridiculous, But that's our healthcare nowadays. That's our healthcare nowadays. Let me see what else I got. I think we'll stick with those two. We'll stick with those two stories today. That was fun. Went about an hour. Like I said, these are going to be sporadic. Hopefully we'll get to a point where I'll be consistent we can have a consistent schedule. I can't commit to that right now because one, it's I run my morning show, Sports Morning Espresso Shot, over at Game On, the biggest sports show here on Rumble. Shout out to you guys. We're about to pass 6,000 followers on here too. That's great. And it's so I do that every day. That's my main thing. That's my fun hobby, is covering sports, and gets me away from my professional life. And yet here I am, like, hey, let's create a show about what I do for my profession. Yeah, that's great. And it's NFL season, so we're going to be busy with that stuff. But I'm going to try at bare minimum do these once a week. I'm good. I'm doing pretty good here. What is this? 2 shows in 3 days? That's pretty good to start things off. I got some other topics we're going to talk about. We're going to get into. Let me see. I can pull them up here. We're going to talk about the cholesterol meds and how they've been a huge scam. More and more studies coming out about that. We're going to talk about fasting. What are the benefits of fasting, or are there even any benefits? Or is it just one of those other diet fads? We'll get into other diet and health, fitness, and stuff like that along the ways too. And I also have a popular sweetener linked to increased blood clots and heart attacks. So we're going to see about some of these synthetic sugars that they make and how they actually are very terrible for you. That one's fun. What's this one? Nope, I have that one. And there was one more right on here. Let me see. Maybe I don't. Come on, where's it at? Poll? There was another one I had somewhere. But yeah, that plus whatever you guys want to talk about, recommend stuff in the comments, subjects you would like me to cover. We can get into in depth on certain things. I can pull up drug articles, drug studies, do whatever. We can dive into things, whatever you guys want to talk about. Like the opioid thing, I wasn't even planning on talking about, but someone in the comments from the last show brought it up. And I was like, hey, that's a good thing. Let's talk about that. Let's go over that. Iceman says intermittent fasting, sugar, except no substitute. Yeah, yeah. I mean, it's all bad for you, right? It's like, what is it? Trump said, what Trump said, "I've never seen a skinny person drink Diet Coke." It's like, yeah, it's not like it's supposed to trick your body. It's like, well, maybe tricking our body's not such a great thing. Iceman, 50K. Do you get a free oil change at least? I wish, dude. I mean, you don't get anything. No, actually, I take that back. I got free pizzas. They give you a free Papa Murphy's pizza, take and bake, one topping. You get a free one. And I got 2 of them. Actually, I got more than 2. I originally was only gonna get 2 of them because I had 2 babies. So like, "Oh, here you go. You have 2 free Papa Murphy's take and bakes." And then I told them that I had a bunch of younger kids at home too, so they gave me a handful more. I think we ended up getting like 5 free pizzas. So, yeah, I got a free 5 pizza. I still haven't used all those. They did come in handy, but still, yeah, I got free pizza at least, so yay. Yay. Wish it came with a minivan. Speaking of which, I mean, God, that was another thing. $30,000 for a minivan. Kids love them. They're worth it though. They're worth it. Anyways, hey, great stream. Good to hang out with you guys. Glad to have you in. I don't know when the next one of these will be, but I had a lot of fun doing this, and I'm actually enjoying this way more than I thought I would. So we'll see what the show ends up growing into. Um, and we're just gonna have fun along the way. And there's gonna be some times that I get in here ranting and raving, and I feel like those are gonna be great days when I'm really ticked off at something in healthcare. So if you can, hit the like button, share this out there with all your friends that might enjoy a show like this. Give me some topics, comment below, give me some topics that you guys would like me to cover. Subscribe to the channel, and I'll see you guys later. If you're into sports and you don't follow my sports show, we do a fun sports show every day, 4:30 a.m. Pacific Standard Time here on Rumble, YouTube X. That's a Game On. So just search for Game On or Game On Show here on Rumble. You'll find me there. We're about to pass 6,000 followers, but yeah, we'll be live 4:30 a.m. Pacific Standard Time tomorrow morning. Got some big announcements for this upcoming month that we're excited to share with you guys this week. That and so much more. We got college football starting up. That's great. I'm excited for that. And oh, hold on, we got something over on the YouTube side of things. What's up? Let's see. No, it's on X, on the X side of things. Misfit Electronic Repair slash Gaming. Yeah, I have chronic pain, and the DA has totally jacked up my meds, lowered me so much I can hardly function some days. I put on the face to stream though on Rumble. God, yeah, and dude, that sucks. That sucks because that's the thing is like they want a one size fits all for everyone, and that's not the case. And I'm sorry you have to go through that, man. Sorry you have to go through that. It's just and it sucks for everyone. It sucks for providers. It sucks for pharmacists. It sucks for patients. Most of all, it sucks for. Like I said, it's not that we don't. At least me personally, I want you to have your meds. If you and your doctor, it's between you and your doctor what you need to be on, right? It's got to be within reason, though. I'm there as a safeguard to make sure we don't actually prescribe the wrong dose or like doctor didn't know you're on a certain med and like, hey, these two meds shouldn't be together. That's going to be a big problem, right? Things like that. But for the most part, I'm just like, okay, this is what you're on. How's this working? And as long as you got a place that like me, like if you were my patient, you could come to me if you were struggling with stuff, if it was too much, or if you wanted to get off of them, there's safe routes for you to do that. Absolutely. But yeah, for the most part, it's between you and your doc. And the fact that the DEA the only people that win in this is the government and insurance companies that win with all this stuff. So it sucks. Sucks big time. But I'm sorry to hear that, man. But glad you're able to, get on there and stream and do something that you love, though. And glad you're streaming on Rumble. Shout out. Shout out. I'll have to check out your show one of these days. Appreciate you swinging by and saying hello. Okay. But yeah, I'll be live tomorrow morning, 4:30 a.m. Pacific Standard Time. Live here, Rumble, YouTube, X, Twitch, all the good places. That's Game On Sports News and Picks or Game On Show. Go check it out. And of course, I'm here, the Uncensored Pharmacist. If you haven't already subscribed there, I got my sweet sign that I'm still trying to figure out. If I turn that thing on, you can't see a damn. It's just one big green blob. So I got to figure out what to do with that. But it's a pretty cool sign that my wife got me for this show. So hopefully we get that up and running. But you guys have a good rest of your Sunday, and I'll catch you guys bright and early in the morning. Until next time, good luck. I can't say my good luck, good gambling, game on like I normally do. Until next time, have a good one.